Okay, audience, so we are back again with again a tremendous lecture. So I welcome you all to Global Interdisciplinary Summit 2020. So with this, we are having our third session of the day by Dr. Shahdad. So before moving on to the session, I would like to guide everyone, all the viewers as well as the participants, kindly register for the certificates as well as the speaker schedule and more details. Kindly visit to the links which are present in the description box. So with this, I would like to introduce our speaker of the day, Dr. Shahdad. Dr. owns and operates dental practices through Vancouver, Canada. After graduating from the University of Toronto, he went on to complete his studies at the Mish International Implant Institute and Surgical Oral Implantology at Temple University with a prime focus on implant and regenerative dentistry. Dr. leads a dental implant study club, teaches surgical and restorative training courses, along with providing professional instruction and mentorship in both implant surgery and prosthodontics across Canada. His surgical and prosthetic instructions and mentorship programs include bone and soft tissue grafting procedures and techniques, implant surgeries, and implant restoration techniques. Doctor has received a number of certifications and recognitions along with being awarded several times the distinguished position of the Diplomate of the American Dental Implant Association, Master and Diplomate of the International Dental Implant Association, Master and Diplomate of the International Congress of Oral Implantology, American Academy of Implant Dentistry, member of International Team of Implantology, Academy of Restorative and Cosmetic Dentistry. He continues to make substantial contribution in the profession through his ongoing study club, course presentation, and mentorship forms. So, I welcome Dr. Shahdad wholeheartedly for the session. So the stage is all yours.
Hello and welcome everyone. I'm not sure if you can see the screen. I cannot see.
So you need to share your screen once.
Okay. Let me share my screen with you. Okay, can you see it now?
Yes, sir. Perfect.
Perfect. All right. So thank you for the introduction. I'm from Vancouver, Canada, and welcome all of you guys to this presentation. We are talking about dentin as autogenous bone substitute material today, which is a great subject and very near and dear to my heart. I wish all of you guys to stay safe wherever you are. These are, strange times that we are at. And hopefully when all of these travel restrictions and everything is lifted, you can come to Vancouver and visit. If you haven't been to Vancouver already, it's a beautiful city. I wanted to thank Dr. Shaw and entire team at GIS for amazing effort that they put together. It's like day and night, 24/7, they are working to put all of the seminars online and for everyone to enjoy it, and hopefully they learn something. We all learn something from it. I'm really honored to be part of this amazing group of speakers, amazing educators from all around the world. So I'm really humbled to be part of the team. We're going to talk about smart dentin grind machine that I use in my offices, but I'm not sponsored by them. So this presentation is not sponsored. I just wanted to tell you that. And it's impossible not to talk about the situation we are at. It's challenging times. Not long ago, we all used to travel and go to all of these meetings and make all of these good memories. And it's so strange for all of us, and I'm sure we are all in it together, as you guys know. Meeting with all of these mentors, educators, great friends and colleagues from all around the world. And Now, if we want to go to grocery store, we have to think twice. It's just so unbelievable. Most of the cities are empty, but I know it sounds cliche, but there's very ancient Persian saying that goes, it too shall pass. We know we're gonna go through it, and we're gonna back to normal and go back to our normal life hopefully soon. So when they asked me about making this presentation and prepare for it, I was thinking about the subject. What is the best subject we can talk about on the global forum? I know internet is packed with all of these great webinars and information from all around the world, from great speakers on digital implant planning, about the soft tissue augmentation, about hard tissue, about sinus, name it. Everything is there on internet. And there is no shortage of excellent webinars and great presentations all around the world. But I was thinking we should have something that everyone can use and benefit from it. Doesn't matter if you're an implant dentist or not, that's just doing general dentistry. And if you are the master clinician, if you are doing implant dentistry for years and you are one of the gurus, or your practice just limited to very basic treatment options such as extraction. So everyone can use it. So that was one thing in my mind. And the other thing, I was thinking in this particular period of time that we are in, it has to be something that is relevant and helpful, and hopefully we can get something out of it in this particular time. So I chose this subject. Using dentin and tooth as bone graft material is not new, and it's not old. A lot of amazing clinicians and innovators like Professor Binderman and Ziv Mazur and a lot of other amazing doctors that we have and researchers, they worked on this. Horowitz worked a lot on that. Rick Myron, Dr. Paul, Dr. Pinto, Nampu, and many others. I mean, to just name the few. So it's very well researched, and a lot of people worked on it. It's not something that is new to implant dentistry. At the same time, it's understated. We haven't used it the way it deserves. So we all, as dentists, I think we all have one goal: to save the teeth and to save the dentition, and make sure we can do everything possible to save the tooth. However, there are sometimes that the tooth is at the end of the road and it has to be extracted, it has to come out. So I prefer to use the techniques such as partial extraction therapy, socket shield, root membrane, and save the tooth, or at least part of it, so we can save the bone around it. But if we pull the tooth, or at least part of it, what do we do with it? And that's a question. We all know, it's a clinical fact, that when a tooth is extracted, it causes significant damage to the alveolar ridge. So a lot of changes happen there. We're going to use the width of the bone and height of the bone. So three-dimensionally, alveolar ridge undergo significant changes. We cause that. And we know when there is no tooth, there is no bone. And when there is no bone, soft tissue follows. And neighboring teeth start to move. Occlusion going to be affected, vertical dimension of the face, facial structure, everything going to be affected after a tooth or part of the tooth is gone. And if you are thinking implant or not, but if you're thinking implant, if there is no bone, there is no implant. Doesn't matter how good keratinized tissue is, or the level of the sinus is, or any other factor would be irrelevant. When we have no bone, it's not going to be no implant. And we all know the best bone around the implant would be autogenous bone, the patient's own. And bone sets the tone. We all remember that, right? So that's the very famous saying, bone sets the tone, at least in dentistry and implant dentistry. We know when we pull the tooth, 3 to 6 millimeters of the height and width of the bone in the first year is gone. So three-dimensionally, bone around the implant, around the tooth rather, it's gone when the tooth is gone. I mean, it's a functional matrix. When we don't have the function and tooth in place, we're gonna lose bone volume. And all of the future treatment option would be affected. Again, doesn't matter if we do the implant or just the denture or none of those things. So in future, the alveolar ridge is not there for us to make the treatment option for that particular part of the mouth or entire mouth. So it's important, and it's very crucial if we can not lose the bone. Okay. Ideally, it's best. Well, I'm talking about most cases, not all of the cases. If we are extracting the wisdom tooth, that's a different story. But ideally, it's best to do the socket preservation after every extraction that we do. So we maintain the bone and alveolar bone. Studies were done, especially with by Dr. Paul and many others, that has been shown when we use tooth structure as bone graft material, bone volume and quality stays better, especially on the buccal side. There are many studies. I'm not going to bore this presentation with that, but bone graft material is superior. Has been shown it has been superior. Depends on the future treatment also as well, which we talk about it in a minute. So why tooth? Why use tooth as bone graft material? First of all, it's there. It's cheap. We just extracted the tooth or part of the tooth, so might as well use it. A study shows that we get great result out of it. And it's very predictable and repeatable. It's not something that by chance we did it once or twice. So predictability is there, and we can repeat the result again and again. And of course, patient would be happier, and we will talk about that a little bit. And of course, it's cheap. We save money. Also, it's another procedure that we do after the extraction. Okay. So it has been shown that volume and quality of the bone, when we are using a tooth structure and tooth material as bone graft, is better. We can mix it with other graft material if we need to. So use of allograft or xenograft or whatever would be less. So we can mix it with other material if we want to, and if we need to. We can mix it with blood or PRF or saline, and handling would be much easier. We can do osteodensification when we use tooth structure and tooth material as graft, which with some of the other material, as we know, osteodensification would be questionable. Okay, and success rate is really high, and healing has been shown it's faster when we use this. When we use extracted tooth as graft material, we can use it as particulate, we can crush it and turn it into powder. We can use it as a ring graft, which is really exciting. We can use it as laminate graft, which is excellent. We can use it in socket preservation and also in vertical and horizontal augmentation. So there are a lot of use for this. So my advice is don't throw it away. You can at least save it. So if you're not using tooth and dentin as bone graft material, at least you can save it. And it is from nature, it's from patient's own body. you can give it back. Okay. Especially in this time that most of our offices are closed, if not all around the world, our offices are closed. We are not seeing the patient, and it's challenging financially for all of us. So all of the bone graft material, doesn't matter which country you are at and which supplier you have and what's your bulk volume or the price tag on the bone graft material that you buy, all bone graft material are expensive. Even the cheapest one is expensive. And when you compare it with the tooth that just came out of the patient's mouth, you know, it's amazing what's the saving we can get out of this. Let's look at the biologics of the graft material. Any graft material, regardless, whatever graft material that we use, it should be, you know, biocompatible. You know, it has to trigger osteoclasts, and hopefully it should not be rejected by the host. Okay, so it stays there and cause the least amount of inflammation and pain. Okay, bone graft material should be bioactive. There are so many graft material out there that they are not bioactive. They are just fillers. But ideally, a bone graft material should be bioactive and should work with the body, with the host, with the environment that we put the bone graft in. It should work with it, not against it. And the bone graft material should communicate with the cells. Has to be a communication going on and bring the cells to create the new bone. Bone graft material, another thing that it has to have, another characteristic which is important, is osteoconductive. It has to create a scaffold, a medium environment that stays there for a while. And this scaffold should support vascularization, so blood can come in it. And it has to support maturity of the graft over time. So it should not be resorbed or disappear too early. Another great characteristic that a graft material should have, ideally, should induce biological process, and it has to send the signals to the body and to the other cells to generate new bones. So if it contains BMPs and growth factors, it's amazing. It's just the best. And it has to attract all of the macrophages and induce the activity so we can get new bone out of it. This dentin and tooth as bone graft material is well studied. So we know about it, and a lot of great people in the industry researched it a lot. They're in the paper and in literature. So many of the colleagues asked about histology. Does it really work? You know, we put it something there and we take X-ray and it looks good, but the proof is in histology. When we put the tooth material there, you know, dentin in this case, if you look here, this is the piece of dentin that under microscope we look at the histology. You can see bone formed around it, and it ankyloses to this piece of dentin. So we get new bone formed around this dentin particulates. And on top of that, we can see the remodeling happening. So not only we have new bone, but also bone is turning over, and we get the new bone and remodeling happening very nicely around the dentin bone graft material. So if you look at the graft, look at this table, this is important. Like I said, biocompatibility, bioactivity, it has to be osteoconductive and inductive. And dentin as a graft material, it has it all. You know, again, advantages are it resorbs slowly, and it is mimics the bone, and it is bone, and we don't need to wait too long. After 2 to 3 months, 4 months maximum, we can re-enter and place the implant, for example. And inflammation is very little. And I just want to go a little bit faster. We don't have a lot of time here. Um, it shows high stability when we use it as a graft material. Healing is fast, and in many cases, we don't need to use membrane. If the periosteum is intact, normally I don't use membrane over the dentin grind material. It has a lot of growth factors and BMPs. It creates new bones, and it regenerates new bone faster, and we can place the implant sooner if that's the treatment plan. It attracts all of the new bones, and we discussed. So hard tissue and soft tissue has a much better response to this, and it's very stable, predictable, less pain, and acceptable, and patient acceptance is much higher. When we use tooth as graft material, there is no cross-contamination, which can be a big issue. A lot of people ask the question about the bone graft material that we're going to use in their mouth. So no cross-contamination happening. It's the same biological characteristics, of course. And there is no manufacturing, preparation, or contamination, possible contamination in it. Also, there is no shelf life. Our office is closed for months right now. One of the issues that we have is a bunch of the material that we have in the office, and we don't know when we open again. What about the shelf life? We have thousands of dollars of bone graft material and a lot of other materials for that matter. And shelf life is something that we all have to think about. With the dentin and tooth as graft material, there is no worry about the shelf life. Actually, we can save the tooth that we extracted for later grafting. So we can save it. And that's the only autogenous bone graft material that I'm aware of that does not need secondary harvesting site. So we don't have to go somewhere else in the mouth or in the body to harvest the graft material. Again, we talked about patient acceptance, which is very important. The big part of this whole thing is patient. Patient ask me, the bone graft material that you use, where does it come from? Almost all of the patients that I talk about graft with them, they ask me, where is the graft coming from? Is it from dead bodies or animal? And some people, because of their beliefs culturally or just personally or religiously, they do not like material that come from a dead body or dead people or animal in their mouth. So when we tell them this is from your own body and going back, they like it. So no adverse immune reaction is happening. Again, as I mentioned before, pain and inflammation is lower, is much cheaper, and you don't need to go anywhere else. Bone graft that come from tooth, again, has a lot of growth factors. I cannot emphasize enough that it is very important. We've got a lot of BMPs and IGF, and as a result, we get superior bone formation and remodeling. So let's look at one case here. I just wanted to talk about some cases. Of course, I don't have access to my office freely as most of us, so we don't have all of the slides and cases and x-rays and CTs, but there are enough evidence here and enough slides that we can go over it. So let's look at one case here. This is a patient, 67 years old, non-smoker, but he's diabetic, type 2. And on the lower right, on the quad 4, you can see the third molar is there with a big cavity on the buccal side. So We try to save the tooth. Patient, it's on the fence, save it or pull the tooth. So we open the caries, look at it. It's subgingivally went too far, so we had to pull the tooth. The patient decided not to go for root canal and all of the other options. So we pulled the tooth uh, and we decided to graft the socket and do implants later on. So clean the tooth, physically, it's very easy. We'll talk about it in a bit. And put it in the grinder. This is the machine that I use in my offices. It's small, it's easy, it's fast, and I get great result with it. So again, I'm not sponsored by this company, but this is the machine that we use. So you see how much particulates we got out of one tooth, or half a tooth, I should say, because it was a lot of caries there. So we did the grinding, got the particulates here, and this is the bone graft material that we got from the tooth. So we put it in the Dentin cleaner. There are two solutions with this machine, which I'm going to show you later. So my amazing staff, they do it, and they are really, really good at it. So decided to do the implant. Patient decided to do the implant at the same time. Now I'm sitting here, so might as well, let's do it. In this particular case, we had to do ridge split because the ridge was very narrow. So we did the ridge split and put the membrane around it because we had the extraction. So we had a little bit of open wound here. Let me show you. So membrane is in place. So we created the envelope. Implant is in place. We did the ridge split and opened the ridge a little bit, widened it. And place the bone graft in, membrane over it, horizontal matrix suture, tension-free suture. So when we do the bone graft with this material or any material, the principles are the same. So we have to have tension-free closure, and we finish the case, place the implant. Initial stability that we checked with IceQ, IceQ value rather, was 77 at the time. So implant in place, both implants, actually we did two, obviously. You can see we don't have a lot of keratinized tissue here. So this is after the healing was completed, initial healing, I should say. Patient come back and I didn't like the soft tissue. Again, all of the principle applies in this as well. So this, but we harvested the free gingival graft from the palate, grafted there, and after 4 months. So look at the quality of the bone on the x-ray. And this is not like perioglass or some other material that it's just a filler there. This is the actual bone, as you saw on the histology. This is the healing of the palate side. And from 77 IceQ value, we went to 87. So in 4 months, we got very good stability, the newly formed bone. And the other tooth is 85, really stable. Okay, that's in another post-op. And that's the final. I believe it's after 4 or 5 months after the bone graft and extraction. Look at the x-ray, and the bone quality around the implants are amazing. These are the implants. Let's look at another case. She's 81 years old patient. She is osteoporotic, non-smoker, and she's retired nurse. So she knows about graft material. She knows about the surgery, or at least she has some knowledge of it. And it's very important for her what kind of material we use and why. So we had a crown that they had to remove. It was a caries underneath. As you can see, it's a lot of damage and subgingival caries. We had to pull the tooth. If you look at the implant in front of it on the mesial side, this is one of my implants, actually. I did implant for her several years ago. And you can see some bone remodeling happening around that implant too. So pull the tooth, discussed it with the patient. She loved the idea of putting back her own tooth, her own genetic codes and everything back as bone graft material. So clean the tooth. There's not much left, a lot of caries. Tooth already had a crown on it. And I'm talking about the cleaning a little bit later. You have to make sure when you do the physical cleaning, the important thing is it should not leave any composite, any amalgam, or any soft tissue as much as possible. Definitely no caries. So you have to clean it, which it takes, 1 or 2 minutes, not long. So physical cleaning is very important. Put it in this machine again. And you see, we don't have a lot of tooth structure here. It's just half a tooth, or half a molar, I should say. With this, we got this much bone graft material almost free after 3 seconds of grinding, which is amazing. All of the material, I don't know who is your supplier, which company you use, which product that you use, but this much bone graft material is hundreds of dollars. So we got that in 3 seconds. We use cleaning solution, which we talk about it in a bit. And again, we did soft tissue grafting here. Make sure we have principles are the same. This is just a bone graft material. It's not a magic solution that can fix everything. So preparing the pre-gingival graft, that's a healing after a week or two, I think 2 weeks. In 9 weeks after the graft, we have this quality of the bone. And if you look at the implant in front of it, which I decided to clean and put a little bit of graft material around it too, look at the quality of the bone. In a little bit over 2 months, we got this quality of the bone, okay? And don't forget, she's osteoporotic and she's like 81 years old. This is after 5 months. I think the bone quality is great. Even the bone around the implant is better. So we placed the implant after 4 months. Okay. So you can see that at the time of the extraction versus 4 months later. Well, we did the implant after 4 months, and this is 4 months after implant placement. So total of 8 months after the extraction. And if you look at the bone level around the implant and the mesial of the new implant. So old implant, which had bone remodeling, I decided to put a little bit of graft around it too. I know it's a different shot. This is a periapical versus bite-wing. However, we got excellent result. ISQ value, 82. I also use AnyCheck. This is excellent machine that we can use as checking the stability of the implant. Old days we used the mirror handle. We go tap 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 around the implant, and if it sound good, it was great. If it not, it said implant is not integrated. Now we have these amazing machines. I love AnyCheck and IceQ. I use them routinely in my practice. And you see at the time of the extraction and final restoration, crown is on, the bone is much better around the implant in front of it on the mesial. probably should go faster. Want to talk about, so very quickly talk about tooth and bone, that they are similar. They are not different. So, well, very similar. Tooth structure and bone structure, they're similar in composition. So dentin is 20% collagen, bone is 25, cementum is 40. Cementum is a little bit more. Well, let me show you another slide here. I think we're gonna be out of time. Let's talk about the protocol, and then I come back to the quality of the bone, or what we get out of it. Protocol with this machine is very simple. We clean the tooth physically, dry it, grind it for 3 seconds, then filter it for 10 seconds. And there is a dentin cleaner solution. We submerge the material in there for 5 minutes, dehydrate it with the gauze, and then wash it twice, and it's ready. In 10 minutes or so, you have the bone graft material. It's autogenous, excellent material, very cheap. For cleaning, you can use anything. You can use high speed, slow speed, piezo, anything you can use. Make sure you dry it. Grind it for 3 seconds. It's like a coffee machine. It has 2 drawers on top. You get particulates that there are 300 to 1200 micron, just excellent size. Depends on the size of the tooth and number of the tooth extracted. You get between 0.5 to 3 cc's. If it's numerous tooth, obviously you get more material out of it. Cleaning for 5 minutes and rinsing twice, and you have your bone graft ready. Simple as that. So when we use tooth from different structure of the tooth, from enamel, you get something like xenograft, which is hardly resorbed and it stays there for a long time. With dentin, you get the cortical bone quality. With cementum, you get cancellous bone quality. And with the new protocol, we got partially demineralized bone, which has much more growth factor in it. And sorry, let me just make sure, take care of something here. So enamel gives us something like xenograft, like I said, dentin, something like cortical bone, which stays there a little bit longer, and turnover is a little bit faster than enamel. So we don't need to remove enamel. When we are doing the cleaning, enamel can stay there, and with cementum, we get cancellous, which turnover is faster. Okay. Another case, we're going out of time. I'm just going to show you this case. She's almost 90. You see I have like 5 teeth extracted, another tooth, cleaned it, did the grinding, and we mixed it with PRF, so we can use a sticky dentin, excellent handling. We put it around the implants, and in few months, you can see and appreciate the quality of the soft tissue, the bone, and this is the final result. Excellent result. An older lady, she loved the idea of using her own tooth. Now, with the new protocol, we use EDTA for 2 minutes, and a lot of a study has been shown by Professor Binderman and many others that the healing is so much faster when we partially demineralized the graft material, because growth factors can be released faster. So this is a new protocol, at least with this machine. Okay, so 5 minutes with the dentin cleanser, and then 2 minutes with EDTA, and then we wash it. So in 8 minutes with the cleaning and everything, with total of 10 minutes of time, you get excellent graft material. You can see the dentin and neobone, which is ankylosed. Again, histology is the proof. I use some of the pictures here. You can see, simply grind the tooth, This is the video from Dr. Al-Ramali. Okay. So we talked about all of this. I go faster because of the time. This is a very exciting case, courtesy of Dr. Ho Lee. He uses a little bit different technique. You know, instead of grinding the tooth, he used the tooth as particulate and laminate graft. You can see the case here. Use a particulate and the laminate. Excellent result after just a few months. Okay. Very exciting way that we can use tooth in grafting is using tooth as a ring. So bone ring around the implant, three-dimensionally. We can augment the ridge and go through the case, graft it. So Dr. Lee uses this machine. He puts the tooth in it. It cleans the tooth and prepare the graft. And there are different techniques. So we don't need all of these fancy, expensive machines, but you know, there are different ways you can use it. You can see the after, excellent result, dentin ring. As I mentioned, we can use it as a sticky dentin, which has the great handling. Mix it with PRF. My amazing team and staff, they do it. They are so good at it. Mix it with PRF and you got sticky dentin. Okay, I think we have only a couple of minutes left. Go over another case very quickly, grind it. Sticky dentin again.
No problem, it can be extended.
All right.
Yes, sir.
So it's another case. He was diabetic and we did the graft and implant for him, but not all of the graft material worked as well. So for him, we had to remove this bridge on the bottom left. As you can see, the bridge was failing and you can see the bone resorption and bone loss around the implants on the upper left. So this is one of those cases, it's not finished yet, of course, because of the situation that we are in. But anyway, we removed the bridge, did the grinding, a lot of material out of it, placed the membrane there, grafted it. Okay, and we're good. And for the life of me, I don't know what it is. This piece of metal here, it just showed on a couple of x-rays and then it was gone. So don't ask me what it is. I think it's a piece of bear or something, but it appeared and then it was gone. So it moved somewhere else and later on it was completely gone. So the bone quality was really good. The case is not finished yet, but we got the really bone quality out of his own tooth in this case. Okay, let me go forward. One of the questions that I get is in the treatment of pre-implantitis and use the dentin graft as graft of choice or material around the implant, you know, in terms of fixing pre-implantitis. I showed you a case earlier that it worked really well around the implant that I placed there, but we didn't have pre-implantitis per se. It was not infected. We didn't have purulent discharge or anything like that. But we just grafted it and it worked well. So I'm not sure if it's the best material or any material for that matter is a good material as a bone graft in treatment of pre-implantitis. However, it was a case that we did. Upper lateral incisor. We had like 7 or 8 millimeters of the pocket. You know, when the implant is not our own implant, it's very easy to remove it. We can just easily remove somebody else's implant. But if it's your own implant, you try everything to save it. Even if you're 100% sure it's not going to work, you want to try and save your own implant. I mean, this is how it is, I guess. But this case, we tried it, removed all of the infected tissue there, cleaned it, lasered it, used the graft material from the third molar, and we got the reasonable result. However, I'm not sure if we can use this for pre-implantitis or we can treat pre-implantitis at all. It's another conversation for another presentation altogether. So in conclusion, it's best to graft almost all of the extraction sites. You have to do different type of augmentation, horizontal, vertical, and tooth works same as bone and even better. It's fast, it's easy, it makes money for the practice, and it saves money. And no expiry date, says no expert date here on number 5, typo, no expiry date, and it works. Okay, something I want you guys to remember. There are a lot of information online, and not only in the world of dentistry, about everything. There are a lot of information online. And you see a lot of things, but remember, not always what you see, it's what it really is. Just look at it from different angle, ask questions, be smart about all of the news, all of this information we get online. So in the end, I wanted to thank to all of our real heroes. We are all in it together in this, trying times. There are real heroes out there, all of those people that put groceries on the shelves, nurses, doctors, truckers, gas station workers, first responders, people who clean the buses and, all of the public transportation for us. And obviously, people that put their lives in danger and their own safety and their families for us. Okay. It too shall pass. Good days are coming and everything gonna go back to normal. So there are a lot of references here. If any of you guys are interested, please send me an email. I'm gonna send you any information, any question that you have. I think we have a few minutes to answer questions if there are any, or you can always email me. Thank you.
Thank you so much, sir, for the beautiful oration and giving us a new idea of, using their own tooth, the patient's tooth, into their bone itself. So that's quite,
Absolutely.
we are not, sorry?
Absolutely. It's an amazing choice. And I was talking to many of the mentors, like gurus in the industry, and even those are a little bit skeptical about it, but histology is there and the result is there. It's an amazing choice.
Definitely, sir. And even more, we are giving back the patient its own tooth. We are not keeping it with us.
Absolutely. Yeah. And it's cheap, Bone graft material are expensive.
Definitely, sir. I wanted to have a question. Like, you are opting for tooth using dentin as bone graft material, but you're taking PRF also. So, but putting only PRF would lead to mineralization of the bone. So, why are you adding extra dentin into it?
Well, something that we talked about, it was osteocontact, the bone graft material, whatever we put there, it should be osteoconductive, right? So PRF not gonna stay there for long. Okay. So we have to add some material to it so that the scaffold stay there for long enough to keep the soft tissue away and give the body a chance to create new bone. So I don't think PRF alone would last that long.
But other clinicians too only use, even in cases of jumping distances, people only use PRF and the things get mineralized.
Yeah, yeah. But well, I use it myself. But like I said, when we compare the results, PRF alone, and we have to look at the defect as well. Do we have four-wall defects or two-wall defects? I mean,
Yes,
these
yes,
are the
yes.
different things.
Yes.
Dr. Paul did a really great study that on the aesthetic zone, they pulled the tooth on the front of the anterior maxilla and used the dentin grind as a graft material. And we got excellent result there. You know, when we put the PRF alone and we have, only two walls around it, not going to have a great result after.
Okay. And does it accelerate the mineralization process?
Dentin?
Yes, sir.
Yes,
Dentin.
yeah, it has been shown. There are studies that has been shown that with the dentin, we get bone formation much faster.
Okay. So we have some questions from the
Please.
audience. Dr. Suraj is there asking that, sir, can we use extracted caries teeth even after cleaning and sterilizing it? Might have microorganisms on it.
Sorry, it was cut off for a second. What was the question again?
Can we use extracted caries teeth even after cleaning and sterilizing it? Might have micros.
Uh, we can use tooth. Yeah, I mean, I'm not sure if I got the question right, but after uh, cleaning the tooth and following the protocol, um, it's a great graft with no limitation. Can use it. Can actually save the tooth. Uh, uh, I'm not sure if I mentioned it enough. We can extract the tooth, and if you're not using it as a graft right now, we can store it either as a particulate or as a tooth itself, and we can come back and several months later we can use it as a graft too.
Okay,
But cleaning is very important. We have to make sure all of the uh, pathogens are gone. Shouldn't be any caries, any filling material. Obviously, we don't want to put composite back in the bone. We don't want to put
definitely,
amalgam back in the bone, right?
definitely.
Yeah.
Yes, sir. Next question is primary tooth and permanent tooth. Is there any difference in growth factors between them?
Excellent question. I couldn't find any research that I can rely on anyway about the primary teeth. Excellent questions, because I was looking around and I myself haven't used it at all.
Okay.
I only used adult teeth, although I had retained baby teeth that we pulled it, but I didn't use it as a graft material because I didn't see enough research on that.
Okay. Um, does the growth factor in the primary teeth would depend upon the organic content? Would that be anywhere related?
Well, we try to clean and get all of the most of the organic material off. I mean, not all of it, obviously, but again, with the primary teeth, I'm not sure. But yeah, good question.
Okay. So next we have, what are the chances of allergic reactions which can occur if dentin is obtained from another donor?
We never ever use dentin for another donor. It only use own teeth for own patient. So same tooth for same patient. So
So the way like bloods are donated, tooth can't be.
no, we cannot use somebody else's tooth grafting in somebody else's body. It's only patient's own tooth.
Okay. So next question is, if the tooth is RCT treated, then how would you use that?
Excellent question. Actually, I wanted to shorten the presentation. I had some slides about it. Some people use the root canal treated teeth as graft material. I personally, I'm not a big fan of it, and I don't recommend it because we have to clean all of the material out of the tooth. Fillings, I can clean the tooth, okay, but root canal, I'm not sure what was the sealer that was used. Can I remove all of the gutta perca and sealer from the canal? I'm not sure of that. It might be some residual sealers that went into the microscopic canals, and I wouldn't recommend it, but some people use it, yes.
But Gutta Perka and sealers are all back compatible, right? So,
Uh, can we clean it though? I mean, before we grind the tooth,
hmm,
I'm not sure if I can clean it 100%.
definitely, yeah. Separating them would be difficult.
Yeah.
Okay. Next question we have: can we treat bone defects too around periodontal compromised teeth?
Yes, a lot of colleagues use that. If you have, actually, we had some cases that we wanted to treat bone defects either around the implants, which again, it's a little bit questionable, but around the natural tooth. And we had the wisdom tooth, luckily. So instead of harvesting tooth from other side of the mouth, we just pulled the wisdom tooth, did the grinding and preparation, and used that as a graft. Yes, yeah, it's an excellent choice.
Okay. So next question is: can we use teeth with periapical pathology? If yes, kindly explain the cleaning process.
Yes, yes, we can. Most of the teeth that we pull, in some of the cases that I put here, they have either perio issues or periapical lesion. You can clean it, and yeah, we can use that, no problem.
So are the canals cleaned priorly?
No,
Because like
you
maybe the
don't need to.
periapical region might have microbes in it.
No, you don't need to clean inside the canals or anything. If the tooth is necrotic, you don't clean it because we put it in dentin cleanser, and that takes care of it. You clean it as much as you can, but doesn't need to be the root canal. Well, we don't need to go inside the canals and clean all of that.
So next question is, please explain how to prepare tooth ring graft.
Tooth ring is a little bit different preparation. We have to put it in different solutions. Dr. Lee does that a lot, and a lot of Korean colleagues, they do it. You can email me. It's a little bit different process, so I can explain it. But it the principle are the same, and we don't grind the tooth. We have to clean it very well. The size of the implant and everything has to be very well calculated, and yeah, it's a little bit different. So it's not as easy as just grinding it, obviously. And the host and the site that we put the ring in, it has to be very meticulously prepared, and then we put the tooth in, the tooth ring, with or without implant. We can put the implant in the tooth ring, place everything together, or we can place the tooth first and place the implant after. It's a little bit different process. I wouldn't recommend it at first. If you haven't been experienced enough with the dentin grind, you don't want to use tooth as ring. Even with the allograft, there are some rings graft material out there by the Strawman or other companies. It's a little bit different process, and it's not something that we want to tackle if we haven't done enough of that.
Next question is from Dr. Rahul. How to save the graft if we have to?
How to?
Save the graft if we have to.
What do you mean save the graft?
I mean, preserve for future.
Oh yeah, we can do that. We can, like I said, you can do a few different ways. Either you can save the tooth itself before grinding, or after you did the grinding and cleansing, you can save it and restore it. You can dry it, okay, dehydrate it with the gauze. And this particular machine that I showed you the picture, Smart Dentin Grind, it comes with a kit that you can put the particulates in it. You use as much as you need, and you can save the rest for future. And then again, it has to be for same patient only. So you can put patient name in it and restore it somewhere for future use.
So, sir, do you think we would be having like in future tooth banks?
Yeah.
So
Yes.
we might have.
Yeah.
Okay. So
So any
next
tooth
question.
we extract, even if we are not doing the graft, we can save it. So I think the worst thing we can do is just extract the tooth and put it in garbage. It's like you buy graft material by hundreds of dollars and just throw it away. Even if you don't use it now, like I said, many surgeons, many of uh, my mentors, they are not doing this at the moment. They are not doing denting grind, but at least we talked about it with many of them that you can save it. So you pull two teeth, you pull wisdom teeth or whatever the situation might be, just save it for later.
Definitely. That's the key. Okay, next question we have is the grinding cup disposable or we can sterilize it?
No, you cannot sterilize it. Well, with this machine, there are different machines. There are some Korean versions that they are much more expensive, and they use different process. But this machine, everything comes in a pack, and in the package there is a grinding part that you put on top of the machine. It's like the coffee grinder, the top part, and it's disposable. We don't reuse it.
Okay.
It's almost impossible to clean it the way that we can use it for another patient. And it's not that expensive anyway.
Okay. Um, so next question is, uh, so we need only patient's fresh tooth dentine with patient's own plasma only, and we are mixing these two things. And when the mixture is placed, then we are placing the sutures over it tightly, so it does not leak out, right?
Well, it has what the principle, like I said, is the same. You want tension-free suture over it. Because when you mix it with the PRF, you get something like a putty, you get like a sticky dentin. It's still firm, but you don't want to put tension over it, like many other graft material. You don't want to put tension over that.
So sticky bone itself will be quite stable, right?
Yeah, yeah, it is very stable.
Okay. Um, yes, sir. Now I think we are over with the questions.
Okay.
Thank you so much, sir, for the session as well as sharing your valuable cases which you have done. They were quite wonderful and even quite helpful and interesting to be shared.
Well, thank you so much, all of you guys, Dr. Shaw and the entire team. And thank you, everyone, for participating.
Thank you so much, sir. So, with this, we'll move on to the end of the session and the day itself. And I would like to guide all the participants that for the speaker schedule or certification related issues, you can all log into the links which are present in the description box. So, with this, kindly stay tuned because we are having all again tremendous speakers like him in all lines. So, stay tuned for tomorrow.
Thank you
Thank you
so
so
much.
much, sir. Thank you.
Stay safe. Bye.
Thank you, sir.